So I'd like, though, to get us started. I want to thank you all for being here and for joining what is going to be a really important discussion, joining our experts as they discuss health and wellness during COVID-19. And we're going to hear from many different individuals. First up will be Dr. Lichtenstein from AgeWell, New York. And he's going to talk about how to learn about COVID-19 affects your body from infection to treatment to recovery. After that, we're going to hear from Dr. Suzanne Sirota Rozenberg from St. John's Episcopal Hospital. And she's going to share with us how telehealth works, what type of in-person visits are available during the pandemic. And then we're going to hear from Gina Aiello, who's the president and geriatric consultant of Caring from the Heart, to talk about learning about navigating the healthcare process for your loved ones. And finally, we will hear from Donna Furey, the law office of Donna Furey, and about the peace of mind of estate planning. My name is Elizabeth Aloni, and I'm with Schneps Media. We're the largest local media organization in New York City. We have newspapers, magazines, websites, and webinars, and events across Manhattan, Queens, Brooklyn, the Bronx, Westchester, and Long Island. We're thrilled to bring you these experts and look forward to being able to bring you many more webinars in the future as well. So without further ado, I'd like to get started with David Lichtenstein, MD. David Lichtenstein is a board-certified internal medicine physician and serves as AgeWell New York's medical director. AgeWell New York offers health plan options for those with Medicare and with both Medicare and Medicaid in the New York metropolitan area. Dr. Lichtenstein held his own practice for over 35 years in Bell Harbor, New York. He also currently serves as the Assistant Chief Surgeon for the NYPD Medical Division. Welcome, Dr. Lichtenstein.
Hi.
So let's get, yeah.
Yeah, please, go ahead.
I was going to say, let's get started in discussing COVID and how it affects the body.
Okay, so the first thing that we have to keep in mind is you keep on hearing about COVID-19 or coronavirus being a novel virus. And what does that mean, novel virus? Well, novel virus means that this virus has never been seen before. And because it's never been seen before, and because of its pandemic response across the globe, we've only been studying it for 3 months. So you hear a lot of conflicting data, you hear conflicting advice from medical specialists on the news channels, you get conflicting advice from the CDC. Unfortunately, we've only been studying this virus intently for 3 months. The real story about this virus may take a year or two to come out. So all the recommendations and all of the so-called facts are still very fluid. So when we talk about COVID-19, what we do know is that COVID-19 is a single-strand RNA sense virus. What that means is there are 2 types of organisms, those that have RNA as its genome or its genetic trait, and those that have DNA. We've all heard of DNA. And the difference between a DNA virus and an RNA virus is that a DNA virus first has to undergo something called mitosis and replicate itself to make RNA. Whereas an RNA virus, the strand is already there and can get immediately incorporated into the cells. So they're much more infectious. And because it's a single strand genetic piece of material, it's very prone to mutation. And unfortunately, that means it's going to be very difficult to get a standard vaccine to an RNA virus that can undergo multiple mutations. Those mutations obviously would make the virus difficult to develop a vaccine to. RNA viruses, most of the examples that we're familiar with are SARS, MERS, influenza virus, hepatitis C. These are all very highly infectious agents that can cause a lot of disability. We call it mortality and morbidity. A DNA virus is more stable. That's like herpes virus. Herpes virus really doesn't undergo any type of mutation. It is what it is. It's not great to have DNA viruses, but at least we know that they're pretty stable in terms of not being able to mutate. Viruses are obligate parasites. In other words, viruses exist to infect other cells. And COVID-19 is a ball-like structure with multiple spikes coming out of it. So it looks like a small sun. That's coronavirus, because corona is like sun-like. Those spikes are R protein or S protein spikes, which are homotrimers. And this is a very important point that we're going to discuss later. What happens with COVID is that either through droplets, which you pass to your mouth, your nose, or your eyes with your hands, which is why hand washing is so important, or aerosol, if somebody sneezes and you inhale the mist from that sneeze, the virus enters your upper airway. Once it enters your upper airway, that S spike adheres to something called epithelial cells. Epithelial cells are a thin layer of cells in your upper airway. It's like your outside skin on the inside of your upper body. And that R spike protein adheres to those healthy cells. And then the corona body itself, which is made of like fat, it's called a lipid bilayer, actually dissolves and the virus is absorbed into a healthy cell. Once it's absorbed into a healthy cell, the RNA single strand protein is actually translated by the healthy cell into what the healthy cell recognizes as almost itself. And now the viral proteins can start to multiply within the healthy cell and actually form hundreds of new viral particles, which can now pass from that infected cell to another healthy cell. Once that happens, you're infected. Now, what's our defense mechanism against viral and bacterial attacks? Well, our first layer of protection is called cilia. And cilia are these small hair-like projections in our upper airway that beat, like little small hairs beating together. And on top of this little hair cells are layers of mucus. When you inhale a foreign protein, a virus or a bacteria, those mucus layers will trap it and kill it. Obviously, if you don't have cilia because you're a heavy smoker or you have obstructive lung disease or something else has destroyed your cilia, you're going to be more prone towards infection. Our second line of defense is something called T cells. And T cells, they're called T cells because they're made in your thymus, which is a gland in your neck. And that gland in your neck is very enlarged when you're a little kid. And these T cells do a couple of things. Number one, they kill things. They're called killer cells. And number two, they have long-term recall. They have memory. And they will remember foreign proteins, viruses, or bacteria that they've seen before. Unfortunately, COVID-19 has never been seen before, which is one of the reasons why it's so infectious and why we're having so much trouble with it. Those T cells, once they recognize a foreign protein, will start to secrete inflammatory mediators. The two that we need to understand in terms of discussions that we'll see in the medical literature are something called tumor necrosis factor, or TNF, or interleukin, especially interleukin 6. Collectively, all of those inflammatory mediators are called cytokines. And you've heard, or maybe you haven't heard, that people who get very sick with COVID have something called a cytokine storm, and we'll talk about that later. But basically, these cytokines will usually kill most viral particles. And once they attach to the virus and start to destroy it, comes our third line of defense. And our third line of defense is called immunoglobulins. And immunoglobulins, or antibodies, come in two varieties. There's an immediate infectious, which is IgG. I'm sorry, IgM. I always get that backwards. And there's a convalescent or recovering antibody, which is IgG. Those immunoglobulins do two things. Number one, they help to kill the virus or bacteria. And number two, they pass immunity to that virus for a period of time. So usually when you make convalescent antibody to a virus, you have immunity. That's the whole basis of vaccines, to simulate an antibody response and develop immunity through your immunoglobulin response or antibody response.
Dr. Why do some people have symptoms that are mild to severe? Why is there such a range?
Well, that's a good question. And the answer is that your immune system, especially your T cells and your antibody response, depend on something called the histocompatibility locus antibodies, or HLA. And in most people, it's robust. But there are subclasses that can make you very sick. The best example is HLA-B27 people. They're prone to all kinds of rheumatological issues, like ankylosing spondylitis or something called Sjogren's syndrome. But most people have a robust HLA system, and that's why most people, and we'll discuss the statistics in a little while, handle COVID very well. If your immunoglobulin response is adequate and your T cell response is adequate, and you secrete your inflammatory mediators appropriately, then you'll have fever, sore throat, possibly loss of sense of smell and taste, possibly some nausea, possibly some diarrhea, and you will be sick with COVID for 3 to 5 days. You will recover, and then you will make antibodies in about 2 weeks. You're still infectious after the beginning of your symptoms for up to 10 days. And we know this because they took people who were infected with COVID and they kept on culturing COVID out of them until 10 days after their symptoms, and after 10 days. So that's the current recommendation from the CDC, that once you are infected and your symptoms stop, that a total of 10 days has to pass from the initiation of your symptoms with mild disease before you can be considered non-infectious.
What could a patient do during the initial phase? What would you recommend to alleviate the effects of the virus from getting severe?
Well, unfortunately, there's been a lot of misinformation about homeopathic remedies, hydroxychloroquine, antibiotics. As of this date, there is no treatment for COVID. There is no way to abbreviate your COVID infection. How you handle your COVID infection is genetically predetermined. Now, if you're diabetic, if you have high blood pressure, if you are immunosuppressed, if your HLA system is not robust, you will proceed to the next phase of infection. That next phase of infection is when the coronavirus travels from your upper respiratory system down into your lower respiratory system. You will develop pneumonia or bronchitis or both. And now COVID attaches to something called ACE2 receptors. ACE2 receptors are angiotensin converting enzyme receptors. Angiotensin converting enzyme is a natural occurring hormone in the body that regulates blood pressure and fluid balance. And it feeds off of hormones secreted by your kidney. Most of those receptor sites are in your lung. A lot of people who have high blood pressure take ACE inhibitors like Vasotec or Acupril or Monopril. One of the side effects is they can get a bad cough. So here, when you have ACE2 receptor sites, which are specifically invaded by COVID, you will get pneumonia. and that pneumonia will cause a certain degree of respiratory distress. The way we measure the severity of your pneumonia is by something called your oxygenation level, which is determined by something called a pulse oximeter. If your pulse oxygen level is above 93%, then you have moderate COVID pneumonia and you're going to be fine. If your pulse ox is less than 93%, then you got to go to the hospital. Doesn't mean that you're going to die, but it means that you're going to need to be treated with investigational medications, which we'll talk about in a minute, and you really shouldn't stay home. At the very least, you should go to the hospital. My recommendation, now that we've passed the peak, it's not as important, but if you are immunosuppressed or you're elderly or one of the high risk groups, and you start coughing or having trouble breathing, you should get your pulse oxygen levels measured, and preferably have a home pulse oximeter that you can check your oxygen levels on a daily basis. As long as they're above 93%, you're going to be fine. Once they fall below 93%, you've gone from moderate to severe COVID pneumonia.
So if someone doesn't have a monitoring device at home, you would recommend, if they're coughing and having trouble breathing, that's a big indicator that they should get medical attention.
They should go to urgent care. They should go to the emergency room. They should have their pulse ox checked. Clearly, their chest X-ray is going to show that they have pneumonia. And what we're going to talk about are certain markers, if you're hospitalized, that will predict how you're going to do. If your pulse ox is less than 93% and you need to be hospitalized, remember we talked about cytokine production, especially tumor necrosis factor and interleukin-6. Tumor necrosis factor can cause blood clots, and it does so on a regular basis. That blood clotting ability can be measured by a blood test called a D-dimer. Your pulmonary involvement can be measured by a blood test called lactic dehydrogenase, or LDH. So when you're admitted to the hospital, when you're evaluated, and they do these blood tests, and these levels are low, and your pulse ox is above 94%, a lot of these patients are sent home, even though they're not better. It's just that they don't meet the critical criteria. Once you're below 93% and you have these inflammatory markers in your blood, you need to be anticoagulated and you need to be started on investigational medication. Remember, there is no FDA-approved therapy for COVID-19.
Can you just repeat, I know you mentioned quickly, what can you have at home to test your oxygen? What is it called that you can have at home?
It's called a pulse oximeter. It's a very simple battery-operated device where you can charge it. I think they sell them on Amazon for anywhere from $50 to $100.
Okay. You know, you were talking about testing, and I think, you know, testing is everyone's talking about it. Can you give us pointers on how to interpret COVID testing? Because we're getting so many different messages about testing.
Sure. So remember that there's two ways to test. There's the nasal swab, which is the viral test. And then there's the blood test, which is the antibody test. And we know what antibodies are because we talked about it. After you've been sick, then you make antibodies. The problem with testing, especially the antibody testing, is you can't test too soon. You have to wait at least a couple of weeks until after you've been tested COVID positive to make those convalescent antibodies. So let's go through, I know, you can't see this because it's too small, but I'll read it. The current COVID-19 test result interpretation guide printed by the CDC. So if you have a COVID swab that's positive, then you probably have COVID, even if you have no symptoms. And you should stay at home, follow CDC guidelines, check in with your healthcare professional if you're having trouble breathing, all the things that we just talked about. Before I go any further, I want to stress that globally, 85% of the general population will recover from COVID with no treatment. In younger patients between the ages of 20 and 50, 93% will totally recover no matter what stage of COVID they have with no treatment. So that's one of the reasons why we have a lot of inaccurate reporting, because in terms of what is effective therapy, how can you gauge what effective therapy is when 93% of the population recovers with no treatment? So that's one of the reasons why there's a lot of questions. Anyway, going back, if your nasal swab is negative, you probably don't have COVID. But if you have classic symptoms, there's a lot of false testing, false negatives in the testing, because they got to get that nasal swab all the way back into your nasopharynx. And they're also supposed to get a swab from the back of your throat. If they just get it on the outside of your nose and you're coughing and you have fever and all the other signs of COVID, you should be retested. Or if you're really feeling bad, you go see a healthcare professional, because a negative COVID test may not be negative. A lot of people had negative COVID tests and the next day showed up to the hospital, they were COVID positive. If you have an antibody test and it's positive, then you had COVID, you recovered, and you made antibodies, even if you never had symptoms. 30% of the population, and they did a study in Manhattan, 30% of the population probably are asymptomatic, had COVID and have antibodies. So that's one of the reasons why when they did the lockdown and everybody had to stay home with their kids who were asymptomatic, COVID spread so rapidly. And we'll talk about kids in a second. If your antibodies are negative, it just means that you haven't recovered from your COVID. If your antibodies are negative and your COVID is negative, you've never been exposed to COVID-19. If your nasal swab is positive and your antibodies are positive, in other words, your nasal swab is positive and your blood test shows that you have antibodies, you're still infectious and you still need to quarantine for 14 days. That comes up a lot. If your nasal swab is positive and your antibody is negative, like we said, you're still infectious. If your nasal swab is negative and your antibodies are positive, then you are one of that asymptomatic group. Very quickly, let's talk about children. Why are children less than 1% of all COVID cases? The following, it's 1%, globally, children less than age 18 is 1% of all COVID cases. Why? Well, remember the thymus and the T cells? They don't have them. They're immature and they don't make those T cells that are mature and can fight and have a reaction and create cytokines until they're in their teens or their 20s. The ACE inhibitors that we talked about, the ACE receptor sites, same thing, you don't make them until you're an adult. So they can't get infected. And finally, when you're a little kid, you're getting a ton of immunizations. All of those viruses compete for infectiousness, and that probably blocks out COVID. So that's why kids are probably carriers. So when we got the shutdown and we locked up all the adults with their children, that's why 65% of new COVID cases came from home.
Well, thank you so much, Dr. This is really valuable information, and I'm sure we could go on with so many others. Let me just ask you a couple of quick questions that we had. If someone doesn't have the funds to get a device for the oxygen, is that something if you know, is that something that is covered by insurance, or is that typically not?
Usually not. Thermometers, pulse oximeters, those kind of things. It all depends on what, so your standard insurance, especially Medicare, is going to pay for that. Okay. But they're not that expensive.
And they're really a lifesaver if you need it.
They can keep you out of the hospital, let's put it that way. If you're coughing and you think you're short of breath and your pulse ox is 96 or 97, you're not as sick as you think you are.
Okay, that's good to know. So also I have another question. An attendee was concerned about people who are smoking. That, you know, even though people are keeping 6-foot distance, if you're smoking, that smoke could potentially go further. Can you catch COVID that way?
No, because remember when you inhale, well, I don't know if you've ever smoked cigarettes, but
I have not.
the physical act of lighting a cigarette, you're lighting a piece of paper on fire and sucking in superheated air. That's what kills the cilia and causes you to be more prone to infection. But that superheated vapor would kill any virus. So it's not like you could exhale virus through cigarette smoke.
Okay, terrific. Well, thank you so much, Dr. Lichtenstein. I mean, there's so much more information here. I think you really gave our attendees important information. I really appreciate it.
All right, be safe.
Yes, you too, you too. So I'm excited now to introduce you to Dr. Suzanne Sirota Rozenberg. She is the Chief of Dermatology at St. John's Episcopal Hospital. Dr. Rozenberg is board certified in dermatology by the American Osteopathic Board of Dermatology and has more than 25 years of experience. She earned her Doctor of Osteopathic Medicine degree at New York College of Osteopathic Medicine. Welcome, Dr. Rozenberg. We're thrilled to have you here. And Dr. Rozenberg is going to talk with us today about telemedicine. So could you please enlighten us about what is telemedicine?
Sure, thanks for having me. And telemedicine is now a very broad name for multiple modalities of how to reach your patients at home. So what has happened is because of, as Dr. Lichtenstein said, that people were pushed into their homes, a lot of people need medical care. And one of the things that we see is how can we get them medical care because they're not coming to the hospital, they're not coming to the clinics, they're not coming to the private offices. So telemedicine was behind the times and there were people starting to do it. But now with everything that's happened with the pandemic, it opened the floodgates and has allowed this platform of medical care to be used. And what it is if you have a computer, a smartphone, it could be an iPhone, an Android, any type of camera device, an iPad, anything, it will allow you to communicate with us. Just like we're communicating now, it's the same thing. So instead of us having a dialogue about, you know, all of this, we're having a dialogue about your medical condition. For those patients that cannot or are not computer savvy and do not know how to negotiate the terms, we can do telephonic or teleaudio. The disadvantage with that is our eyes are not on the patient. However, in triaging the patient, we're able to speak and advise them if they should come in or not, or see their healthcare, doctor. So it is used on various platforms. You're on mute.
Excuse me. So you're able to use Zoom. You're able to use these platforms that allow you to see the patient. And then you also, if worse comes to worse, you could use the phone, but it limits your ability to really be able to see everything that's going on with the patient. So,
what's interesting, Elizabeth, is that in the past, you were not allowed, it had to be a HIPAA secured platform. And right now, Medicare, and therefore a lot of the insurance companies followed suit, are allowing us to use Skype, WhatsApp, other ways to get to our patients. However, this is a very limited scope of use. It's only going to be for a few more weeks. Otherwise, it has to be on a HIPAA compliant platform, such as Zoom, which is what the hospital uses. Also, we use through our AthenaNet for our iPhones and iPads. And there's DoxyMe and Doximity. Those are all ones that are being used more commonly and very easily. And what it is the patient from the privacy of their home can talk to us. When we see you, we will ask you to confirm, the patient will ask to confirm their date of birth and where they're at and that they consent. These are requirements that are necessary to consent, and we need your date of birth because many times, you don't know who that person is, which is also a new change. Telemedicine was never allowed to be done on new patients. It was only on existing patients. And there's been a waiver so that even new patients can be seen. I would tell you that telephonic is not a platform to use for a new patient when you need to see them. So telemed telehealth works that way.
You were mentioning that some of that is going to change in 2 weeks. Is that about the new patients or is that existing patients as well?
So, everything is every day a changing atmosphere here. And we get, probably Donna will talk to this more, but every day, we get new rules and regulations. We were never allowed to talk on Skype because it's not HIPAA compliant.
Mm-hmm.
However, because of what happened and the rush to get as much care to our patients, understand that right now we're missing 150,000 patients a month for routine healthcare. The potential damage in the future is huge. So, COVID deaths that everyone talks about and looks at, that's just a small part of the fraction of lost healthcare. So this is a way to capture healthcare again. And especially, your elderly patients that cannot or are afraid to come out into your office or to the clinic. This right now is a viable alternative for them to be seen.
Absolutely. So what telemedicine services does St. John's Medical Group offer?
So we have quite a list. And depending on which office you go to, of course, I'm a little prejudiced. Dermatology is, my favorite one to do it on. So we offer derm, we offer family medicine, internal medicine. GYN, OB is a little bit more difficult, but they're trying. You are offering it also in hematology, oncology. They have it. Infectious disease, orthopedics can be done. Neurology, it can be used versatile wise all over. Rheumatology, they can all be offered in different ways.
Wonderful. How does someone schedule a telemedicine appointment?
So there's a flyer that everybody, has access to. And I think at the end of the webinar, we can give the number to the clinic. Depending on which office you're accustomed to going to, there are different numbers. So you have Beach 20th Street. You have us at the hospital clinic on the 5th floor clinic that everyone knows me from, where we're seeing patients, and we'll get to that in a minute. You have your community health centers that are attached to us, Beach 19th Street. By the way, peds, and I said family med, those are also being done all through telemed. And so we have a lot of access and the different numbers for the different sites for you to go.
And we'll share that flyer with all of our attendees. Do you still, talking about telemedicine, but do you still offer in-person appointments? Are those still happening?
Absolutely. Listen, let's be honest. We can't treat everything through telemed. Somebody has for dermatologic reasons, somebody has a growth. I can look at it, but between the pixels and the resolution and all, sometimes it's just too difficult. And we have them. We are seeing dermatology patients at the clinic, at the hospital on Fridays now. And hematology can see patients that need to be, because they need their bloods checked. So that's important. Orthopedics is seeing patients in the clinic. So depending on what you need, you can't fix a broken bone on the phone. It's just
right.
Telemed. So these are the things. A lot of well checks are being on telemed, but if you're sick now, being sick, there's a lot more out there than just COVID. So we put this and enacted this platform pretty quickly. I'm pretty impressed with the hospital and how fast we got it going, because we don't want to leave out those other patients. We don't want deaths from things that could have been prevented, high blood pressure, from and if your blood pressure is skyrocketing, you can be seen at the hospital. And if you do have an emergency, you can be seen in the ER. There are ways that we'll talk about, I think is the next set, about what we're all doing to ensure your safety when you're being seen.
Yes, if you would please share that, because obviously that's on everyone's mind when you're going to an in-person visit, even just a visit, forget about the ER. What kind of protocols do you have to keep people as safe as possible?
So one thing, my clinic was a very busy clinic, and we could see 40, 50 patients in a session. So there's been a change. We can't do that right now. So we can reassure our patients that that's not being done. And what it is between everybody must come wearing a mask. And if not, the hospital provides you with a mask at the front desk. Everybody is triaged on the phone when they're confirmed. So they're asked, do they have a fever, cough, shortness of breath, myalgias, loss of taste, things that, we know are COVID because of the transmissibility of it, as Dr. Lichtenstein had said. And so the triage begins on the phone. If you have any of those symptoms, you're not going to be seen in the clinic. Then we schedule our patients. Right now we're using 2 rooms. We do our best to keep nobody in the waiting room, especially not more than 1 person. So they come in and they're put directly into the room. And any paperwork or anything we fill out in the room. And then after that, they are seen, they're registered, they're seen. The doctor's wearing a mask and protective, personal equipment. The patient is in a mask. And if we have to look around the mouth or take, we're trying to use our social distancing and being careful. So when they come in, they're social distancing. They're put into the room. So if I have 2 rooms available, we can see 2 patients. They're let out at different times so that there's never more than 1 person at the desk. And then they're let go, and then the next person comes out. Between each patient, the rooms are sanitized and cleaned with either Sani wipes, alcohol wipes. The whole room is wiped down, the bed, the table that they're sitting on, the chairs, the computer. And we wait about 10 minutes between each one to let the room dry out. And then we put the next one. We are here to ensure your safety. The last thing we want is to be the transmitter of disease. So we're doing things that we can to minimize the exposure. But our patients have to do their part and not be insulted when they're asked. And we also check their temperatures. If I didn't say that before, when they come in, before they're seen, they are screened with a temperature.
So it certainly sounds like St. John's Episcopal Hospital has a lot of measures in place to be as safe as possible when these in-person visits need to happen. And you've made very clear that sometimes they really do need to happen, and you don't want people to shy away from it when it can be something life-threatening that's outside of COVID.
Absolutely. I can't impress upon everybody enough. When this whole thing broke, the American Academy of Dermatology said, okay, came out with recommendations. And it said, if you have a skin cancer, you can wait 2-3 months till this all settles down. And then you can be seen and have it treated. Well, we're at that 3-month mark. If we're honestly talking, this has been around since January. So we're now starting June. We're at that 3-month mark. We're at that 4-month mark, and skin cancers must be treated. And your blood pressure must be checked. Your diabetes must be checked. These things, your asthma must be checked. There are things that must be checked, and we don't want those to fall to the wayside just to avoid coming to the hospital. So we've done our part. They also screen at the front desk at the hospital. So there's a lot of ways that we're doing our part to ensure your safety.
Well, thank you very much. That's very important information. And we'll have on that flyer, we'll also have information about how people can make in-person appointments. But I very much appreciate your walking us through how telemedicine works, how patients can get help without having to come in, and also the importance that you are there and doing all the protocols that need to be there to keep people as safe as possible when they do have to come in person, and how important it is to take all your healthcare seriously. It's not just COVID. There are other things that are very critical. So thank you so much for that.
You're welcome. One more thing is, our ERs, especially with all the news hype and the way media and the way it was handled, everybody became afraid of going to the ER. The ERs now, and the census in the hospital is down, the ERs are empty, and they are taking precautions. So they are available for your emergent, needs, and we shouldn't forget about them. They're not just there, again, as COVID needs. We need our ERs to stay afloat. And now that we've flattened the curve and we've gotten back, we now have to get back to good medical care.
That's great advice. Thank you so very much for joining us. Your information was invaluable. So now I'm going to turn to Gina Aiello, who is from Caring from the Heart. Gina Aiello currently resides in Port Washington, Nassau County, for over 30 years with her husband and children. In 1989, Gina attended St. Joseph's College in Patchogue and graduated with a bachelor's degree in psychology. She obtained her master's degree in social work at Adelphi University in Garden City and is licensed in the state of New York. As a social worker, Gina worked in various facilities such as Winthrop University Hospital, Winthrop Dialysis Outpatient, Pathways to Independent Living, and nursing homes. Throughout her career path, she found her passion working with the elderly population and their families. In 2010, she formed her company called Caring from the Heart. Caring from the Heart is a geriatric care consultant company that provides a wide array of services to the elderly and their family members. These services include home care visits, discussion of financial issues, assessment of care needs, coordination of home care, nursing home placement, and processing Medicaid and pooled trust income applications. She oversees several people within her company. She has a working relationship with financial planners, elder law attorneys, we'll hear from one of those shortly, geriatric care managers, home care agencies, managed long-term care plans, and Department of Social Services throughout Suffolk, Nassau, New York City, and Westchester. Gina has a professional affiliation with the National Association of Social Workers and Gerontology Professional of New York. Wow, that is impressive. Thank you, Gina. Welcome. We're so happy to have you here.
Thank you for having me, Elizabeth.
Absolutely. So, I think one of the things that people are concerned about and as they look at COVID and they look at their loved ones is, how has COVID changed the process of getting healthcare in place?
Well, first of all, home visits are no longer being made in the home. As a social worker, I would go into the home, meet the family, meet the client so they can develop a comfort level to see who I am, because you're discussing their finances, you're discussing their medical needs and their cognitions. Nurses are no longer going into the homes to do the assessments. So that is a disadvantage in a way because the nurses are not really seeing the patients. So when it comes to determining hours, it's being based on telephone as opposed to in-person visits. And most of the caseworkers from Department of Social Services are working from home. So they're not in the building and they're coming in on rotating schedules. So the cases are taking a little bit longer to get approved for home care. So there's a delay in getting home care in place for the clients.
Wow. So what protocols do you have in place during COVID to keep families safe? As you were saying, there's a lot of these things that are changing and people aren't coming into the home. What are you finding to do to be able to keep families safe?
Well, it's a challenge. So a lot of conversations being done over the phone, which turns into a 2-hour conversation. FaceTime meetings. People are not comfortable mailing their documents through regular mail, so I'm setting up FedEx accounts. And recently, depending on the client's comfort level, I'm meeting clients in parking lots, wearing masks, wearing gloves, and keeping our distance because families are not comfortable just speaking over the phone and just handing everything over. They want to see you. They want to put a face to who you are because you're helping their loved one getting care in place and they want to know who you are.
Absolutely. I mean, nothing is more personal. Nothing is more personal than, loved one and their health care and their financial health, and all of those things are so personal. So I can understand that. And wow, you really go above and beyond in being able to make sure people feel that comfort. So how does someone navigate the healthcare system on behalf of the elderly?
Well, it's important to start, in my profession, to start with a social worker and or a geriatric care manager because they are the focal point. That social worker will go in to assess the client's physical needs, to assess the client's cognition needs, to assess financial, and coordinate the home care, getting different vendor agencies in place, which is all an important aspect of getting the care. Another aspect is making referrals to the managed long-term care plan, like AgeWell. I work closely with AgeWell. Referrals to elder care attorneys, which is very, very important because you want to get your documents in place and get everything together. And the social worker in my field, the most important thing is, we advocate for the hours for our client to get the care in place and to get them the hours that they need.
So you really hold their hand, having to deal with all the different tentacles of being able to get care for their loved ones. It's not just a one size fits all. It's not one.
It's not. I mean, the whole process can take up to 3 months, but I just don't stop. When you process a Medicaid application, I don't stop. You got to go to the next level. And if that vendor agency is not working out, where the aides are not compatible, then it's contacting another vendor agency. If that MLTC didn't approve the hours that we're actually looking for, then it's making a referral to another MLTC plan. So it's very hand-holding, it's a continuous process, and then it doesn't stop.
And how would one ever navigate it alone? I mean, to be able to have someone like you that is, knows what to ask and knows, where to turn and what should be. Another question that I have for you is, I think people are very nervous about nursing homes and, all of this in the news. And so I'm sure a lot of people really want to keep their loved ones at home. How would someone go about that process?
Well, to keep someone at home, there are several options. First option we know is that they can pay privately for home care. They can pay privately, and eventually their money's going to run out. If they have a long-term care insurance policy in place, that insurance can pay for the home care. But most of the elderly people, they're applying for Medicaid. They work so hard, they paid into the system, now it's time for the government to help them. So we start with the process of Medicaid, and it involves certain steps. And it is a process, it's a journey. It's getting all the pieces together in the puzzle. And it's reviewing the financial eligibility. It's reviewing income eligibility. It's gathering all the documents. It's putting all the forms together. It's completing the application. It's interfacing with the caseworkers at Department of Social Services. And it's arranging for the assessments that take place after the Medicaid is approved, because most of these elderly people, 98, 95, 90 years old, they want to be in their home. This is where they lived all their life, and they want to age in their home. And, sometimes nursing homes, you have to go in to pay, each case is different, but a majority of them, they want to stay in their home. And it's hard to uproot a 90-year-old woman to have them get used to now nursing home and the care and the aides. It's a lot.
Well, it's wonderful that you're able to help navigate it, because as you were listing all of those things, I felt like I was getting dizzy. So that's really, an important piece that families know that there is you to go to be able to pull all that together. I understand that there are major changes happening in home care. What are some of those major changes in the future?
Yes, and I'm sure Donna is well aware of what's going on too, but yes, there are major changes that are happening with home care. Effective October 2020, home care now for eligibility, they're going back 30 months. So it's producing 2.5 months of bank statements, savings, checking, CDs, stocks, IRAs, the life insurance, where today, as it exists, we only have to show 1 to 3 months worth of bank statements. So they're going to go back 30 months. And another major change is transfers. If a loved one transferred money to their children or transfer money into a trust, that's going to penalize them. It's going to penalize them for getting care. Nowadays, you're allowed to transfer money. You can transfer money to your children. You could transfer money to a trust, and you're still able to get care the following month, and you won't be penalized for that. So those are such major changes. And then when it comes to activities of daily living, you now must have 3 areas that you need the care in. eating, mobility, transfer, and toileting. So those are major changes, and it's all being worked out. So I advise all my clients that if you are thinking about it, getting home care for your loved one, now's the time to do it before October, because we don't know what's going to happen.
That's an important
It
message.
really hurt them.
Yeah, that's a very important message.
Mm-hmm.
Let me ask you, since we have you here and you're the expert,
Well,
what special tips do you give your family and friends? Is there a special tip around all of this that, you know, maybe you can give us the insight on?
I always tell my clients, you don't want to plan in a crisis.
Mm.
Go seek an elder care attorney, get your documents in place, get your power of attorney, get your living will in place, get your healthcare proxy, because if mom is able to make her needs known and then a year down the road, mom has a stroke and now she can't verbalize, it's difficult to get a power of attorney in place. And I'm sure Donna can, you know, understand what I'm talking about. So you want to get all that information in place. And, you know, Medicaid is a puzzle. It's putting all the pieces together, and you don't want to plan in a crisis. You want to be able to get the house out of your name and don't wait to the last minute, because look what's happening. There are changes coming October 2020, which is going to impact the elderly.
Wow, that's really good advice. You don't want to wait until it's an emergency. It's
Don't.
wonderful that you're here today learning about this so that everyone who's on this call can make sure they don't wait and that they move forward with these plans. Let me just give you a couple of questions that we got from the attendees.
Mhm.
You know, one question is, how are social workers making assessments now if they're not going into the home, or are they going into the home? How are these assessments being made?
Well, in my field, I am not going into the home, so it's doing an intake over the phone. So taking out your review sheet and going over their finances and listing everything down, going over their cognition, doing a mini mental test over the phone, you know, tell me the date, tell me, you know, reviewing the medication. So it's following a list and following a protocol of questions that I've developed to ask.
So you've created a way that you can do this over the phone and be able to get all the pertinent information that's going to be necessary to move to
And
the next.
also reaching out to their doctors by having them sign the HIPAA form, reaching out to their doctors and collecting information from there.
So you become the conduit to all these other specialists to be able to pull it all together. Wonderful. And one last question for you before I let you go. I'm sure you have a busy day and this has been really very helpful. Someone wanted to know, why do you think that they're making the change from 3 months to 30 months in terms of the home care? And maybe that's, you know, a crystal ball
you know what, from my perspective, it's cutbacks. Government needs to pull out. I mean, this was on the talk many years ago about taking away spousal refusal. They didn't take that away. So government.
the reality of the finances.
Of what's happening in the world today.
Thank you so much, Gina.
Thank you for having me.
Helpful. Obviously, you know, what you do in caring from the heart is a phenomenal service that you provide to families to be able to take care of their loved ones and be able to make it through all of these complicated steps that they need to take. So I thank you so much. Really appreciate you being here.
Thank you for having me. Thank you.
Absolutely. And now I am thrilled to present to you Donna Furey. She's of the law office of Donna Furey, and we've been mentioning the importance of elder law, and now we're going to have a chance to hear right from her. I wanted to just let you know that Donna has received her law degree from St. John's University of Law. She's currently the chairperson of the board of directors of the Catholic Lawyers Guild of Queens, treasurer of the East River Kiwanis Club, chair of the Elder Law section of the Queens County Bar Association, and was past president of the Queens County Bar Association, the Astoria Kiwanis Club, East River Kiwanis Club, and the Catholic Lawyers Guild of Queens. She co-chairs of the Elder Law section of the New York State Women's Bar Association, and she provides legal, proactive care for your most sensitive life planning manners. Welcome very much to our conversation. You're such an important part of planning for your future and for your family. Can you share with us a little bit about what are the basics that someone could have in terms of estate planning?
Well, I mean, thank you for having me on this panel, and I do appreciate what everybody else has been saying. But basically, I think one thing to remember is that everybody's different, and everybody's a different individual, has different needs, and there's always a different story. So very often, people listen to their friends, and they say, "Oh, well, my friend said, my friend," and they're very wrong. I'm sure it could apply to anybody's situation. The question about why is there now going to be a 30-month look back as of October 1st is a budget issue, definitely for New York State, and it was passed with New York State's budget in April. The spousal refusal has been on the chopping block for quite a few years, and so far we've been able to preserve it, but the New York State Bar Association Elder Law Section has been a really big fan of, we really get out there and do our lobbying to try to keep these benefits for all of our clients. As far as the documents that right now, with the COVID experience here, I'm getting a lot of calls with either there's two different situations. Either there's someone who's in the hospital or in the nursing home who needs help, that they don't have documents in place. And so the families are trying to get access, like how can they actually be involved in the medical decisions without having any paper documents. And basically in New York State, I want everybody to know that the New York State Healthcare Decision Making Act, and that act was passed in 2010, and that allows family members to be able to make decisions for people in hospitals and nursing homes if those people cannot make decisions for themselves. So, I mean, that can help someone who's like trying to I can't get any answers from anybody. And so then as far as documents, if they have documents in place, that's great. The documents you're going to need for medical decisions, I think that, Gina had already referred to them, and so did Suzanne, is that, you need to be having your healthcare proxies in place, your HIPAA releases if that's something that's necessary. A healthcare proxy, if you can't make decisions for yourself, someone else is you're appointing who you're going to make them. A living will can be helpful as well, where you're making decisions already for yourself about life-sustaining treatment. So these are just some of the documents that are very helpful to have for medical situations. And for those documents, you can get them for free on the New York State Department of Health website. So I think that's a very good site. You can learn a little bit about, some of these documents, and you can actually print them out, sign them in front of two independent witnesses, not the people that you're appointing, and you can have them in place immediately.
Well, you made a very good point, Donna, about, that you've been seeing people who haven't had these documents in place. And not only is it stressful when a family member is obviously in the hospital and at the end of their life, but then to add on to it, not knowing what they want, not knowing what to do is probably the worst time to have to make those decisions. And so, it's so important in terms of the planning to be able to make sure that you get in front of that for your own peace of mind, but also your family. You don't want to leave your family at time of mourning when they should really just be focusing on the grieving process, having to focus on all these very difficult decisions and paperwork and legal things they have to jump over.
Yeah, for sure. It's definitely better when people plan in advance. I'm getting lots of people getting calls on that as well. And also some of my clients who've been procrastinating have been giving me calls. I've also been getting calls where people are saying, well, this person wasn't that nice to me during the COVID crisis here, so I want to cut them out. So, I get all kinds of calls. But I mean, it is a very serious situation. And I'm also seeing, the other thing that I'm seeing very lot of is people passing of COVID that either they have documents in place, which is great, where we can maybe be able to get a funeral done and do different things. But very often what I'm also seeing is that even if they have some documents, they don't have all the documents, so they don't have a complete package or picture of what they really should have in place. That's the difference between going to an attorney and just doing it all on your own, because you might miss something. So what happens, I've been seeing a lot of apartments and houses being sealed by the police department because the person passes, they don't have a will, they don't have a disposition of remains, we don't know what to do with the body. I mean, it becomes a nightmare, basically. for this person who's just passed and we don't know what to do. A disposition of remains, again, another free document you can get on the New York State Department of Health website. And basically, if you, the person who really needs this is someone who doesn't have family members, who just has friends that are really their family. And so they don't have the, right, as of right, easily to just take control over the body and all of that kind of stuff. Unfortunately, I don't get to talk about fun stuff a lot. And so basically this document, they can appoint whoever it is that they want to be able to, deal with, the cremation or the burial or the this and the that, so that, there's some dignity in, in their passing. And like you said, the grieving process is horrible too, so like to be dealing with all of that at the same time is, it's just a lot on the individuals and the families.
And isn't that important, even if you do have family, finding out the burial, where do you want to be buried? How do you want to be buried? There are things that perhaps we don't love to think about, but the alternative really is people not knowing what you want, and them so much wanting to do what you want. So, even if you do have family, to be able to give them that information and have it in an organized fashion, and working with an attorney who can make sure you don't miss anything. I think, one thing that I learned in getting a will is like, I don't even think of all the what ifs. That's kind of, what's so helpful in going to an attorney, is that they can really help you assess what it is that your personal family life structure needs to protect yourself.
That's very true. I mean, the basic documents that most people need, again, it depends on your age, it depends on your situation. So everyone is individual, would be the will, which really says, this is where I want all my assets to go. You should also put beneficiaries on assets. So this way we can avoid going to court. Any day you can avoid going to court, it's a good day. That's where trusts come into play a lot of times. And a power of attorney, a very good power of attorney, can be very helpful with our Medicaid planning, our estate planning, and things that need to be done on an emergency basis. But of course, it's an emergency document. That's what I like to tell my clients, because you don't want to give people control over anything unless there's an emergency happening. And your healthcare proxies. Those are the basic documents that if you can have them in place prior to things happening, it's going to be the better situation for you and your families, without a doubt.
Can you give us a quick top line of what you mentioned, a will in terms of saying where things go and to whom they go to. Can you give us a quick top line of what a power of attorney document provides?
Yeah, so everybody knows what a will is. It's, you appoint an executor, they handle your assets to make sure that everything goes where you want it to go. They have a big job to do. They usually hire an attorney to help them. A power of attorney is where you're appointing someone to help you in case of you can't do things yourself. Say you're in the hospital, you can't pay your bills. You need to get somebody to go to the bank and pay the bills, or you need them to go grocery shop for you. Whatever that you need them to do for you, this is what's going to help them to do it. As an elder law attorney, this is a very important document because it helps me usually help to do emergency Medicaid planning if I need to do it. I help people get either nursing home Medicaid, or sometimes I always work with geriatric care managers and social workers to do community Medicaid because as Gina was saying, it is a very detailed process. It's a hands-on thing. You got to get the aides in there. There's a lot of work to be done. I think it's better suited. I'm sure a lot of attorneys aren't going to like hearing this, but better suited to have geriatric care managers doing it because they are professional and they know how to do it. We usually help get the assets and affairs in order for them to apply. And the documents that we need from the legal side. That's how I like to work with it. Because
so you and Gina working together are really the 1-2 punch that ensures that everything is covered and that you have the support that you need to be able to make sure that all of your loved ones' needs are met. That's
the goal. That is the goal. And I guess right now. The thing that is also, the CARES Act has, a lot of people need extra money. They need money. There's the $1,200, the stimulus package that hopefully everyone's getting. If you're not getting it, you need to get online and, apply for it in case you haven't done your tax returns. So anybody receiving Social Security should be getting it directly deposited. The CARES Act also allows for loans from 401ks and retirement plans. So you can make a loan if you need to get some money out in order to just carry you along. I mean, people have mortgages that they have to pay. There's so many, variables for everybody in every age group, not just elderly people. So, there's different things out there that can help you get through this hump. So like with the borrowing from your plan, you can borrow up to $100,000 and you don't have to pay the penalty you have 3 years to pay the penalty or return the money. So that gives you some leeway there. You have some, you don't have to take the required minimum distributions right now if you don't want to, because everybody's financial plans are tanking with all of this with the financial markets. So there's a lot of different opportunities out there that the CARES Act is trying to help us to manage and stay afloat no matter what our financial situation is. And again, yes, the new law with home care is going to be really difficult. It's not going to be easy because a 30-month look back is definitely not going to be something that's going to be easy to deal with. So we have a lot of challenges going forward. So do your planning now. That's what I would
absolutely.
suggest.
I think that this crisis has certainly shined a light on the importance of this kind of planning because, as you were talking, Dr. Rozenberg, it's not just COVID that can strike you or your family. There's many things out there and none of us know what tomorrow brings. And although we hope it's wonderful, if you plan for something that's going to happen to everybody, which is die, if you put that plan in place, you can feel a lot of security and a lot of weight lifted off your shoulders. I know that when I put my will into place, it wasn't even something I was so aware was weighing on me, but I definitely felt, the weight lifted after putting that into place and knowing that I protected my family, my children. So it's, now's a perfect time to really look at that.
And people with children, usually they're appointing guardians as well in their wills. In case something happens to them and their significant other, they want to say, who's going to take care of my kids? So, I mean, that's what happens with, people who are younger. You need to, definitely. Hopefully that's what we do is try to make everybody's life a little more peaceful.
Amen to that. So I have a couple of questions from you from the participants I'd love to ask. One person said, what percentage of your assets does an executor get by handling the matters?
The executor's fee is statutorily dictated. So it's a sliding scale. They get 5% of the first 100,000, of the next 200, it's 4%. Of the next up to $1 million, like 700,000 is 3%. Above that, 2.5%. So it's a sliding scale, and it's by statute. So it's not you can't negotiate it.
So it's depending upon what the value of the estate.
Yes, it is definitely.
Okay.
I have seen wills where they have said, okay, my executor can only get 20,000, let's say. And that has been enforced. So you can say that if you're, but, the executor does have a job to do. So it all depends on, how much you want them to get, if you want them to get the statutory amount or if you have a different feeling for that. So you're the boss. So when you do your will, whatever you want. And then I try to make it happen, basically, find a way.
That's the important thing, is really getting to what do you want in all these areas that you might not have even realized are areas that are require decisions. I think that's, step one in being able to connect with you. So it's really important.
Definitely. Yeah, you need to start to think about who, and some people don't have a lot of people to even appoint to different positions. So then what do? So what you might want to pick somebody to be a guardian in case you lose your mind or something. So there's a lot of different, exactly. Every person's a separate individual with their own thoughts, their own desires. And so it's whatever they want, we figure out a way to make it happen.
That's wonderful. Before we wrap up, I wanted to just ask you this question as well. Like, do you have any tips that maybe you give your family and friends, anything that,
Well, right now, unfortunately, I would say, If you might need to get multiple death certificates, if you're gonna be getting death certificates, if someone has passed from COVID, you can get them also at Vital Check, which is, an online thing, but you have to be in the class of people who are allowed to get it, okay? You can also check insurance policies. So there's a New York State, again, I'm happy to provide this information, I guess, after the fact here. A website the Department of Finance has where you can search for insurance policies, okay, to see if the person who passed has any insurance policies. You can also see, you're gonna need to see, do they have a will? Don't they have a will? Right now, so that makes a difference on how you're gonna be able to proceed. Right now, you can't go to the courthouse. Sometimes people file their wills with the court. It's not the usual way to do things. Sometimes they put it in a safe place in their apartment. Sometimes they put it in a safe deposit box. So there's different ways to, we got to try to find it if we can. Usually you could go to the courthouse and look
where everything is.
Yes, that could, right? Yeah, exactly. So again, this is where you got to tell your family, I keep it in the box, in the drawer, or wherever it is, or if I have safe deposit boxes is a whole nother can of tricks because we have to go to court to open up the box usually. So, right now that's something to consider. Oh, right now throughout the state, anybody who has passed with COVID is getting priority, their states. So, I think that's how New York State is trying to also expedite things that are for people who have died suddenly from COVID. So I guess we got to find the will. If we can't find the will, then there's a whole nother procedure that we got to follow. You can also contact Social Security for whoever passed, see if there's any benefits there, workers' compensation, or their employer, if that's something that might also be a way that you can do that. I'm just trying to think of different things that would be helpful.
Well, once again, this shows you why it's so important to have have an attorney like yourself who can walk you through this, because it's as I was saying with Gina, it's dizzying, and it is as unique as each individual is for their situation, and there's really no other way to be able to put in place what you need for yourself and your family than meeting with you and having all those questions answered, and you asking the questions that we may not even know to ask. So, this has really been valuable information, and I appreciate your being here very much. And I wanted to let all the attendees know how much we appreciate your being here. And we will follow up via email with the contact information about all of our wonderful speakers. They will be able to reach out to you and provide you with information that they provided here as well. And thank you so much for spending some of the afternoon with us here. And I hope you all stay safe, stay sane, and stay healthy. Have a wonderful day.
Everyone does. Wear your masks. Wash your hands.
Wash your hands. Wear your masks. Thanks so much.
Thank you.
Bye.
Bye-bye.
Thank you.